Good morning, everyone. I'm going to be talking about my research with Dr. Iskandar for the past few years. I have no disclosures. This is the outline of the themes I will be covering. I'm going to start with the relationship of chronic overdrainage and proximal shunt malfunction. As Dr. Iskandar explained a few weeks ago, we have observed that chronic overdrainage is a leading cause of proximal shunt obstruction. These are intra-op imaging of endoscopic shunt revisions of patients who presented with shunt malfunction. And we can see how the ependymal tissue, various degrees of ependymal tissue being pulled into the proximal catheter holes. Like here, this is very mild. You can just see the bumps. Here we see longer tissue being pulled into the holes, and here we see how the tissue is stuck in the holes, causing acute hydrocephalus and patients presenting very sick. So we and others understand that gravity is the major cause of overdrainage. However, we have also did some mathematical simulation and showed that even in the horizontal position, when there is no gravity, there are forces that act on the ventricle that can cause overdrainage. And these can be physiologic from the cardiac pulsations, breathing patterns, or movements that the patients do, such as Valsalva. Another group in Germany recorded ICP pressures in a shunted individual over 24 hours as they were doing their daily life activities. And we can see here that the ICP is not a constant number. It varies a lot and can go up to the 60s with certain maneuvers such as coughing or using the bathroom, which means that these valves are always open and can be overdraining. So since we cannot test this hypothesis in humans of being supine and how pulsations work, we decided to build a platform to test all these valves. And this is the current platform we have, and it's located at Wimmer. And this platform incorporates what we think are the three most important physiologic parameters that contribute to shunt function. And these are the compliance, pulsations, and gravity. In the center here is the pseudoventricle that mimics the brain ventricles. And we have constant inflow of fluid from a reservoir and a pressure head that is regulated by a one-way valve. There are three pressure transducers, one inside the pseudoventricle to measure the intracranial pressure or the pressure in the ventricle, one right before the valve and one right after the valve. And here's the valve that is connected in series, just like in humans. This part here is the distal catheter, and this is what we use to simulate the vertical orientation for gravity and the horizontal orientation. These are the compliance chambers that we use to simulate the different brain compliances that we're interested in. And here is the pulse pressure generator and controller that introduces different pulse waves into the pseudoventricle to mimic or simulate cardiac pulsations and other Valsalva maneuvers. And we did some experiments, and here is what we found. First, as expected, gravity is a major source of overdrainage. If we look at this, these two graphs here, on the y-axis is the outflow through the system, and the x-axis is the different experiments. The red lines are the drainage patterns under gravity in the vertical position. And we see when there is no valve in the system, there is so much drainage happening. However, when we add a valve, this drainage decreases but is not eliminated, which means that valves slow down the flow in systems but do not decrease it as much as to the horizontal position. And then we wanted to see what do pulsations do on the valves. So in this graph, we have different pulse pressure values, and on the y-axis, the outflow. And we can see that in the horizontal position, and not the vertical, As the pulsations are increased, these are the solid lines right here, the outflow increases. This effect is not seen in the vertical position because gravity is the major source and the pulsations are diminished. So we wanted to understand how overdrainage is taking place and what is this overdrainage. As we were doing more experiments, we started to observe that there are two states of CSF drainage in each experiment. One that we call a transient state, which is a very short period of time where we have dumping or high values of drainage, and then a steady state. Ideally, we would like a patient to be in a steady state because if a patient has a valve set at 12, we expect that the ICPs or the intracranial pressures remain at 12 throughout the day and the night. However, this is not the case because there's a transient state happening where the valve is open and dumping all this fluid. And we see that overdrainage is primarily happening in the transient state, regardless of the orientation, pulsations, or the brain compliance, and can be up to 300 more times than the steady state. So now we wanted to look at how is gravity related to this in each of these states. We looked at the transient state, which is the fast state, and the steady state, which is the somehow stable state. And we see that there is overdrainage in both states. If we look at this graph here and the y-axis, even in the steady state, we have overdrainage in the vertical position, but not as severe as in the transient state, which is like 300 more or 30 times more or 300 more times than the horizontal position. We then looked at the steady state, which is the state we would like our patients to be in. And we saw that in the vertical position, and this is because of gravity, the pulsations really do not affect the outflow. And this is depicted by this graph. The different colors are the different compliances that we use. And we see that in the vertical position, we don't have tremendous increases in drainage pattern. However, when we remove the gravity from the equation, in the horizontal position, we see that as the pulsation R increases here on the y-axis, we have a slope of drainage. And we can see here on the y-axis as the outflow increases with more pulsations. So what happens in the transient state? And this is the state that we think all the patients are in at almost all the time. Again, when the patient is vertical, this transient state overdrained is primarily by gravity, and the effect of pulsation is minimal. Even when patients are horizontal, we see that the effect of pulsation is much more signified in these states. You see how steep the slope is. What does that mean? It means that the transient state is the state where the gravity and the pulsation has the most effect. What does this mean to a patient? A shunted patient who is up and around during the day is always moving, running, coughing, using the bathroom, eating. So this means they are always in a state that is open and draining. Even when they go to bed at night and we eliminate gravity and they're sleeping, the mere cardiac pulsations and breathing patterns are keeping this valve open and draining to some extent. Now that we have shown that chronic overdrainage is causing proximal obstruction and it really exists on the bench, is there anything we can do to decrease that? So I'm going to show you the role of anti-sapping device in decreasing the overdrainage pattern. We have shown that adding a second valve in a shunted patient decreases the rate of proximal shunt obstruction anywhere between 60 and 80%, depending on the complexity of the patient. For example, in these two graphs, these are simple patients, that is, patients who has had less than 10 proximal shunt obstruction revisions in their lifetime. And we see a 67% decrease after 1 year having this anti-7 device, and this decreases to around 43% after 5 years. In more complex patients, that is patients with more than 10 shunt revisions, proximal shunt revisions in their lifetime, this effect is even more signified by 76% after 1 year of having 2 valves in the system and 66% after 5 years. Similarly, another group in Germany published a 90% decline in shunt malfunction rate, especially proximal obstruction, in patients who got 2 valves at initial shunt placement. However, at that time, they could not explain why they have this improvement in shunt malfunction. And many people over the years have shown the importance of anti-siphon devices in shunt function other than proximal obstruction. Some showed how it decreases the rate of subdural hematoma, subdural hematomas. Others shown how the ventricles increase in size over time, and others shown how the slit ventricle syndrome also decreases. But nobody really explained how or why the anti-7 devices are doing that. So since we have this system, we decided to add an anti-7 device to the apparatus, and this is here where we place it on the distal catheter. And indeed, when we placed a second valve in the system, we see a dramatic improvement in the outflow. Here on the left is the traditional one-way valve, that one-way shunt valve that we use, and we see how high the outflow is. But as soon as we add 2 valves in the system, this outflow rate decreases. And now we ask, what is the optimal position? How far apart should these 2 valves be for the best function or result? So we added the second valve at various distances, starting at 1 centimeter and 5 centimeters from the first valve. And we can see here, if the anti-7 device is 5 centimeters away from the first valve, we have better results than if it is 1 centimeter away from the first valve. And as the distance increases, the effect is even better. The outflow is better at 10 centimeters, at 20 centimeters, though we see we did not go beyond 20 centimeters so far. So now I have shown how anti-7 devices decrease the proximal shunt obstruction rates and how they decrease overdrainage on the system. One can ask, is there any valve there on the market that works better than the other, or that does not require an anti-siphon device for function? So we bought almost all the valves on the market. We got a state grant, state of Wisconsin grant, and we bought 3 replicas of almost all the valves, and we started testing these. And to answer these questions, we decided to start with extremes. So we got the Shabra valve, which is a $60 valve used in India, South Africa, and other low-income countries, and compared them to the programmable valves that are used in high-income countries such as the Strata and Certas. And this is what we found. The Certas, the Strata, the Delta, and are very comparable to the Shabra valves in both the horizontal and vertical position. What does this mean? None of these valves are smart enough to detect the orientation of the patient, the intracranial pressure of the patient, or the brain compliance of the patient. So they all work the same, with no difference in their function. This is all prelim data. So in conclusion, overdrainage is the dominant cause of shunt obstruction, primarily proximal, and most of the overdrainage is happening in the transient state. And this is the state that the patients are in almost all the time, even when asleep. Decreasing the overdrainage using anti-siphon devices significantly decreases the rate of shunt malfunction clinically. And the farther the distance between the valve and the anti-siphon device, the better the effect on the patient. All commercial valves, regardless of the cost, overdrain because they do not take into consideration the gravity, pulsations, or compliance. Why is this important? Because to design a future shunt system, the valve should be able to detect the orientation of the patient, the brain compliance, and the instantaneous intracranial pressures. This is the team, and thank you.
Joyce, what did you learn from just the experience of doing the research? What did you learn about yourself or about investigating ideas or translating this to patients?
I am still learning, and I think we don't know a lot, and we just take things for granted of what others say. And it's our responsibility to find answers and make improvements. Oh, yes, all the time.
Powered systems to do that, but is there, you ever tried anything that's not powered, just mechanical? Determine that.
I don't think just mechanical will work here. We need something that is smart enough. I mean, we've seen, despite years of advancement in the technology and the current programmable valves that say that they work in a certain position more than the other, that they all work the same. Because if a patient, for example, the pressure is set, let's say, at 20, and the patient is upright, the siphoning catheter is always longer than 20. So the valve is always open. And the valve does not know when the patient is supine or upright. So I don't think just mechanical. I think what Dr. Iskander is working on is the smart valve, which will take into account many of these factors.
Well, maybe passive. Because that's possible. Maybe not for that to give us science. The problem is that with the antiseptic effect, we're obviously significantly mitigating the problem. And we're trying to figure out how to optimize it even this level, number of them. The problem is that instead of the shunt failing at 1 minute, they'll still failing. And that's the
as I was watching, I was thinking, if there was something that changed the buoyancy, it could understand the orientation without power. Because having seen the designs, obviously these are great and could also work, but the dumber the technology, the longer it's going to last.
But the antiseptic devices, that's what they do. They're dual. In the supine position, it is one pressure, and they detect the upright position. In fact, it's a gradual thing. And now we have to program them to set what the vertical position setting should be at without messing with the horizontal position. So it's all improving what we do, but it's just
Not good.
Suspicious that these mechanical devices pass on the catchment training state. They eventually get to a point where they can actually hold the siphoning effect back. But if the majority of the drainage is occurring during the transit states and all responds to transitions.
so. Mark, I would ask you the question that Bob asked Joyce. When you start with this, tell us what you've learned. What kind of things you would advise other people.
The most important thing is to, and once we just don't lose the forest of the trees. Pretty easy to do. There's, I mean, mission and prospects, we're very focused on this. Probably increase the more visits. I think now that I've gone through this further edge methods and more visits are one thing, it's another thing is patients that are chronically bedridden instead of some symptomatic problem, which is really a more focused on it.
I think the other important point is what is the long-term benefit of that also why do we have it? And what is the long-term deficit of changing as far as cognitive function and growth of brain and connectivity of brain? This is where we have the tools to begin to ask these questions. And I think we're going to learn a lot. We just go back to saying, why is it this stuff? Some of the people, I feel that it's a way to move large amounts of blood in and out of the brain and hurry, which makes sense. And we lose that because we have to moderate the speed, the stuff that it makes, we lose that. So the smart valve be really smart to respond as immediately. But that's the goal.
One thing I would add to this, because we were talking about a special population, pediatric patients. Eventually, we have small benefit. What about the patients who benefit longer? Right, the ones who come in the large. So Steve Schiff did a project in Uganda that showed that kids who come in with really large heads, there is a 30 to 40% incidence of subdural function. So they can't collapse their ventricles to obstruct the shunt, but what they do is develop subdural. And I think we see that with some patients, we see it with some adults who, not just with the tumor population, and that's the kind of thing that can be expressed differently in different parts.